Hello, anatomy colleagues. This is Dr. Alsop, and in this video, we will be discussing the joints of the ankle region. So the true ankle joint, but also the surrounding and associated joints. Three learning objectives to keep in mind during this discussion. Make sure to answer these in your own words to gauge your understanding. And we will start with the proximal most joints in this region, and these are the joints between the tibia and the fibula, the tibiofibular joints. There are three separate joints, similar to what we had in the forearm between the radius and the ulna, with one pretty big difference. The proximal most or superior one is pretty similar. So we're going to have the superior tibiofibular joint. It is a plain synovial joint. So synovial like most joints of the appendages. But there's a big difference with the other two tibiofibular joints. They're actually fibrous joints. Specifically, they are syndesmoses. So we will have the interosseous membrane between the diaphysis of the bones. And then distally, we will have the inferior or distal tibiofibular joint. So a fibrous joint confers a bit more stability, but there is slight movement to help with stability, particularly with stability as well as a little bit of flexibility you will need for locomotion. And this will help with the actions that happen at the true ankle joint. It is at these syndesmoses and specifically the ligaments associated with them, that high ankle sprains occur. So either damaging the tibiofibular ligaments or the interosseous membrane itself. This type of injury will often occur with really, really excessive twisting. And these injuries are much less common than a typical ankle sprain, but are more serious, and with that comes a longer healing time. Now let's move to the true ankle joint. Scientifically, we call this the talocrural joint. Recall that the leg is sometimes referred to as the crura. The articular surfaces include the distal tibia and fibula. Particularly that distal tibia has a good amount of that surface area for articulation. It will also include those distalmost projections of the tibia and the fibula. So you'll have the medial malleolus and the lateral malleolus. And these are articulating with the talus or ankle bone. And those malleoli will serve to grip the talus during the actions of this joint, which are in essence hinge motions. So the ankle joint is a synovial hinge joint, but instead of the standard flexion and extension terminology, at the ankle specifically, we have what is called dorsiflexion and plantar flexion. And these words are describing where the flexion is occurring. So where is that reduction in the angle? So with dorsiflexion, there is going to be flexion at the ankle with the dorsal side of the foot. Think pointing your toes up off the ground. Plantar flexion is flexion at the ankle with the plantar surface of the foot. So think pointing your toes down towards the ground or standing on your tiptoes. These movements are super important in terms of locomotion. And as always, we have these videos of actions of the lower limb if you're getting confused by these. And these movements very, very rarely happen in a vacuum. They almost always happen in uniform with some movements that occur in the neighboring subtalar and transverse tarsal joints. So the subtalar is between the talus and the calcaneus, and the transverse tarsal joints are between many of the tarsal bones. And these specific movements are called eversion and inversion. Eversion will have the plantar surface or the sole of the foot. It's going to move away from the median plane, so moving laterally. And inversion will be the opposite. The sole of the foot moves towards the median plane or moves medially. So if you are able to or would like to try out some of these movements, or you can watch those videos of the lower limb movements shared in the previous slide. And if you see these, which one of these actions has more range of motion? Inversion, and usually by quite a bit. and that has a lot to do with the ligaments in the region. So let's talk about them. On the medial side, we have the deltoid or medial ligaments of the ankle. And these are on the medial side. They almost form this complete wall of ligaments on the medial side. And they all share a proximal attachment on the medial malleolus or malleolus. And importantly, they mingle together. And again, they're just strong. They provide a lot of stability here. This is a major reason why our range of motion with eversion is less than inversion because these ligaments stabilize the ankle during eversion. The lateral ligaments of the ankle are another story. We have three separate ligaments. They all do attach to the lateral malleolus. You can't see the third one very well, it's back here in this illustration. So they're all attaching on the lateral malleolus of the fibula, but they do not intermingle and they are not nearly as strong as on the medial side. And these ligaments will stabilize the ankle during inversion. And when we get an over-inversion injury, you can have damage to any of these ligaments, but particularly the anterior talofibular ligament or the ATFL is one of the most, if not the most, commonly injured ligaments in the body. And that is because ankle sprains are common. I am fairly sure either you or someone you know has had an ankle sprain. Think stepping off a sidewalk unexpectedly or stepping on a rock you didn't see and your ankle rolls, which is a more common way of saying you overly invert your foot typically, which puts strain on the ligaments in the area, particularly those lateral ligaments of the ankle. And of the lateral ligaments of the ankle, that ATFL is the most commonly injured. In fact, if you have damage to one of the other three ligaments, you can predict that you have also injured your ATFL. The severity or degree of the sprain is dependent on damage to the ligaments and how many of them are damaged. So you can have a fairly small sprain to a very traumatic, long healing time type of sprain. To the practice question, the talocrural or the ankle joint is capable of plantar flexion and dorsiflexion. So which kind of joint is this? All right, so plantar flexion and dorsiflexion are different than the terminology that we're used to. So let's try to figure this out. Well, these words do have flexion in the name, so we can mark out the plane joint. Plane joints are not capable of flexion. And we can also mark out syndesmosis. Recall, these are fibrous joints, so they're not capable of much movement. So these two are out. The other three joints are capable of flexion. Plantar flexion and dorsiflexion are an up and down movement in one axis. So that sounds very hinge-like to me. The other types of joints, the condyloid and the ball and socket joints, are capable of moving in more than one axis. So all signs are pointing towards C, hinge joints being the correct answer. Excellent. Thank you so much for your time and attention.